We are pleased to welcome Dr. Cara C. Lewis. Cara C. Lewis is the Deputy Director of the Center for Translational Research and Implementation Science, or CTRIS, I think, at the National Heart, Lung, and Blood Institute within the National Institutes of Health. Dr. Lewis has a Ph.D. in clinical psychology with a research focus on advancing pragmatic and rigorous measures and methods for implementation science and practice. Please give a warm welcome to Dr. Cara C. Lewis.
Good afternoon. Thank you so much for having me today. I plan to talk with you about articulating implementation mechanisms to optimize for things like impact, efficiency, and equity, but other types of outcomes or parameters that you care about in the implementation work that you might be doing. So before I jump in, it's important that I acknowledge I have nothing to disclose, and the contents of the presentation should not reflect an official position of NIH or the Department of Health and Human Services. I'll do my best to monitor the chat as we go, but it might be easier to tackle questions and comments at the end, and I promise to save 15 to 25 minutes for discussion. So, something a bit wonky is happening on this slide, but I will do my best to introduce you to Dr. Elvin Gang, whose picture is featured here. He's one of my favorite implementation scientists. And when I heard him share this story out in SIRC, the Society for Implementation Research Collaboration conference in 2022, I asked him if I could borrow his retelling of a story. So I'm retelling a retelling of the story of vitamin C and how it surfaced as a cure for scurvy, because it struck me as a really nice value proposition for articulating implementation mechanisms that I think most everyone can appreciate. So I thank the brilliant Dr. Elvin Gang for this version that builds an incredibly compelling case in my mind for studying implementation mechanisms. So, as you all know, scurvy was a devastating disease that killed perhaps 2 million sailors before the 20th century, often claiming half of a crew. And as we now know, vitamin C contributes to the formation of collagenous tissues, the material that keeps your blood vessels, joints, and gums intact, and its absence can be fatal. In 1747, James Lind, a surgeon, tried an experiment that made history. And moving to the experiment, it went like this. He got 12 sailors sick with scurvy and put them into 6 groups, 2 in each group. He gave each group the candidate treatments that you see here. The 2 that got the CTRIS recovered dramatically, while the others languished. This finding is hailed as an early, if not the earliest, successful clinical trial, and Lind has gone down in history as a scientific hero. However, the results were not successfully or consistently taken up for 50 to 100 years, and admissions for scurvy at this typical hospital in Britain continued to be high for at least 100 years after Lind's experiment. So here we have a fabulous example of what we now refer to as a no-do gap. It's clear that the CTRIS theory had far less of an effect than it could have. This is where implementation science enters the scene. As with everything we undertake in implementation science, the truth is far more complicated. So even though Lind found that CTRIS led to recovery, no one knew the mechanism, vitamin C. And it's tragic in a way because Lind himself confesses in his final writings on the topic that he doesn't understand what he observed. Some ships boiled the lemon juice to concentrate it, but it inactivated the vitamin C. Sailors got scurvy, casting doubt on the CTRIS theory altogether. So in Dr. Gang's words, this is not the story of a man with evidence and the failure of a system to use it. It's the story of a society that did not understand the mechanism of an effect and therefore could not understand how to use the evidence. So intuitively looking back, if you understand the mechanism, you wouldn't make the same mistakes. But it's really not just about mechanisms. And I have been talking about, writing about, thinking about, studying implementation mechanisms for years now. And to me, it's an entry point for this important conversation and study around answering the question, what works for whom, under what conditions, and in what settings. So I now feature one of my other favorite implementation scientists, Dr. David Chambers, who also at a CIRC meeting, but this one back in 2017, characterized the field of implementation science by across the decades by a single question. And so in the 2000s, the question that was driving empirical inquiry was really what got in the way. So we had all of these evidence-based programs, practices, policies, pills, et cetera, that were not getting integrated into the settings for which they were intended to benefit those who could stand to benefit. And so there was this slew of studies on barriers and facilitators to unearth what got in the way. And a seminal paper that I'll just highlight for you came out in 2009, published by Laura Damschroeder and colleagues, that folks refer to as the CFIR, which is the Consolidated Framework for Implementation Research. And it tries to wrap its arms around the domains and specific constructs that emerge across implementation initiatives as barriers and facilitators. Now, moving ahead a decade, the question that really grounded empirical inquiry was, well, what works? So we understand what's getting in the way. The barriers range from intrapersonal to system level and beyond. What works to overcome or address these barriers and achieve these outcomes of interest? Well, here we have a seminal article from 2011 and then updated in 2015, a compilation of implementation strategies. So 73 discrete strategies that could be deployed to overcome barriers in a variety of contexts was shared, almost like a menu of what we could utilize to integrate evidence and evidence-based practices and programs. So here in the 2020s, I really hope that we see more and more people answering the question, well, how do these things work? How does it work? Under what conditions and in what settings, for whom, when, and why? And so just featured on the bottom of your screen is a systematic review we published in 2020 that looked at the implementation studies around the globe that seek to establish implementation mechanisms. And I'll say a little bit more about that study as we move forward. So what I sort of alluded to already and tried to share a compelling story about why I think mechanisms matter so much in implementation science, but I'll say also from my new hat, my new role that I stepped into in April 2023, it has become even more important from my perspective to study implementation mechanisms, because we see 3, 5, 7-year trials of implementation strategies, oftentimes yielding null findings. And what a significant investment for our community partners to go through such a long study and not realize the integration of evidence or evidence-based practices that they'd hoped for. And so I wonder if we slow down and think causally and are very precise in selecting, matching implementation strategies to barriers, perhaps we'll surface those that hold more promise of achieving the outcomes that we hope to impact, and that it would be done in a more resource-sensitive way. So you might be familiar with this relatively new textbook called Practical Implementation Science, but really trying to make sure that the implementation science that we do yields practical results for practical impact. And so I don't think people often put the term mechanisms together with practical. So that's my challenge for you today, is to see if you might agree that articulating mechanisms can really help us from a practical perspective. And so here are some practical comments I hear in the community all the time. So this strategy works here and here, but not over there, and that there's really no implementation without adaptation. And so if you've heard or said those sentiments yourselves, how is it that we can take findings of a promising implementation strategy and stand those up or scale them without studying implementation mechanisms? So that's the sentiment, is slowing down to think causally, articulate implementation mechanisms to be a little more explicit in step 2 here. So for me to build this case, I want to make sure that we're all on the same page in terms of terminology. And so I will define terms and then build out a causal pathway of an implementation strategy using what I hope is an accessible, concrete example. So if you're an implementation scientist or practitioner or community member or policymaker who funds or leads implementation initiatives, typically we're all coming at this from the same perspective in terms of wanting to achieve implementation outcomes. These are the effects of deliberative and purposive actions to implement new treatments, practices, and services. And you're probably very familiar with the implementation outcomes framework that Enola Proctor and colleagues published in 2011 that has 8 outcomes on the left-hand side of your screen. And they're intentionally depicted in this cascading order to influence service outcomes and ultimately client or patient outcomes at the end there. And I put a little flag by penetration, which is an implementation outcome, because when you're thinking about implementation and centering equity, some folks say penetration is a sort of a natural equity related implementation outcome because it seeks to understand what portion of the intended population is benefiting from the evidence-based practice. But there's also some really important work in recent years around how to bring equity into each of these implementation outcomes. So just flagging that for your consideration. So here comes the example, implementation outcomes sitting on the far end of our causal pathway. And let's say the outcome we want to achieve is the evidence-based guideline is met for depression screening rates in primary care. So hopefully that's an accessible example, whether or not you work in a health system, you might be a patient and have actually completed a depression screening measure in a primary care clinic. So the outcome of interest is depression screening rates to the guideline standard. Well, how do we get there to that outcome? This is where implementation strategies come in. These are the methods or techniques used to enhance the adoption, implementation, sustainability of a clinical program or practice. And I mentioned that there were 73 discrete strategies. In a 2014 compilation, there are over 100 documented now. You can organize implementation strategies in lots of different ways. This is from the 2011 paper that Byron Powell and colleagues wrote, where they organize strategies in terms of plan, educate, finance, restructure, quality management, and policy context types of strategies. And I just featured a few discrete strategies on the right for you to get a sense of what those might look like. So back to our example, if we're trying to get depression screening rates to guidelines, perhaps we use a depression screening electronic health record decision support prompt. And so why would we use that strategy to get to that guideline? Well, it's likely because of certain barriers that we've been made aware of. But before we talk about barriers, I wanted to acknowledge that when I think of equitable approaches to implementation and being resource sensitive, particularly given the nature of implementation studies happening with community partners in community settings, I really think it's important that we feature more proximal outcomes. So you saw in the Proctor and colleagues framework that implementation outcomes are more proximal than service and clinical outcomes, but we need to be thinking even earlier than that and evaluating earlier if our implementation strategy is working as we think it should, giving us a signal of an effect. So if we're deploying an electronic health record decision support prompt, and we want to get to the depression screening rate at a guideline level, we really need to be seeing clinicians or care team members administering a depression screener, let's say the PHQ-9. That should be an early signal that we might be able to get to this guideline rate. But if it's the electronic health record decision support prompt, there's a really observable proximal outcome here that we can be looking for, and it's that a clinician endorses even being reminded. And that's very specifically tied to the implementation strategy. So what I'm trying to center here is that if we are really precise about picking a strategy because we think it'll overcome a barrier, which I'll enter in a moment, then we should also see that the strategy is working through the mechanism of action, which I'll enter also in a moment. But the earliest signal that's observable might be that the clinician is reminded. So I've been using the terms barriers and facilitators, but the more jargony term is determinants of practice. And these are the factors that obstruct or enable changes in targeted professional behaviors or healthcare delivery processes. Now, this fascinating study, and forgive me for not including the citation, by Krause and colleagues that came out of the Multinational Tailored Implementation for Chronic Diseases study surfaced 601 plausible unique determinants in their study, which I just think is sort of mind-boggling. But I also believe it. Determinants emerge across levels of patient, provider, organization, community, policy. You can organize determinants in different ways in terms of inner setting, outer setting, determinants related to the intervention characteristics, determinants related to characteristics of individuals. And I've put some examples on the screen of what people are characterizing as determinants in some implementation studies. So where do determinants feature in our causal pathway? They're the thing that get in the way of achieving the outcomes that we care about. So it has been discovered that primary care teams have a whole lot to do. They have so much on their plates for a given visit that their attention is divided. And so if indeed that rings true for a local context or care team, divided attention as the barrier, then I would believe it that a decision support prompt in the EHR where they're working during the visit holds promise at achieving their outcomes of interest of upping the depression screening guideline rates. But how can we convince ourselves that that causal pathway is plausible? That's where we bring implementation mechanisms in. So these are the reasons why change occurred or how change came about. It is a process, not a state, and there should be this conceptual relatedness, if you will, between the barrier and the mechanism. So the mechanism is, as I said, a process, but we give it a label for these artificially linear, overly simplistic causal pathways that we're painting on the screen for you here. And the mechanism should hold promise in overcoming or reducing or addressing the barrier. So a decision support prompt in the electronic health record should activate this enhancing of salience of screening to overcome the divided attention to then get PHQ-9s in play during a visit. This is a causal pathway that really features impact, getting to the sort of effectiveness level of guideline adherence, but we can have a totally different causal pathway emerge if we have a different type of outcome that might be more related to equity. So perhaps we're trying to reach underserved groups who have primary care visits, and perhaps there are languages other than English where depression screeners need to be made easily available and translated. And so a very different implementation strategy would need to be used than an EHR reminder to do a screener in order to achieve that outcome of interest. And so easing access to other languages is a mechanism that would need to be activated to overcome the barriers in those instances. So this is what we think of as the trunk of a causal pathway diagram, and it's meant to be a thought tool, you know, just a way to unpack a thorny problem, center barriers that are getting in the way, and convince yourself that the strategy you've chosen actually does hold promise in achieving the outcomes of interest. But there's nothing really special about those diagrams. You could cook up a table like this. So what you see on your screen now are the same factors, but just put in a table. So you've got an implementation strategy. I always pick on education because it is people's favorite go-to implementation strategy. If providers just knew more, if they just knew about it, then they might deliver the evidence-based intervention. But when we really unpack education, we might realize that it actually doesn't hold promise of achieving the outcome that you care most about. So education works through awareness building, maybe some knowledge acquisition, hopefully, to overcome things like provider knowledge deficit. But can they get us to fidelity to an intervention? Depends on what the intervention is, but probably not. The farthest they might get in an implementation outcome cascade is adoption. But what if we had training that consisted of teaching with practice and corrective feedback? Well, that mechanism of action might include acquiring and refining skill growing mastery. That might overcome a skill deficit, and maybe that holds promise of getting fidelity to an evidence-based practice. Here's a different strategy of train the trainer, which operates through embedding expertise in a local context. And that can overcome the determinant of turnover, which is a threat to sustainability. And I'll just feature one more example here, which is the clinical champion-led implementation team. That specific operationalization of an implementation team being led by a clinical champion holds promise of activating implementation climate. So the extent to which an evidence-based practice is expected, rewarded, and supported. And that can overcome the determinant of provider engagement and perhaps lead to increased perceptions of feasibility, acceptability, and appropriateness of an evidence-based intervention. So wanted to share a few more examples of strategy causal pathways that kept out a clinical example, but the causal pathway isn't done yet. So these are the branches off the trunk of the causal pathway that I think are particularly important when you're thinking about equity. Preconditions for mechanism activation. So these are factors that simply must be in place for a mechanism to be activated and the subsequent causal events to occur. So I keep seeing folks deploy more costly, more complex implementation strategies that simply cannot be stood up in under-resourced environments. And if we're really pushed to consider the preconditions, we might choose different implementation strategies, particularly if we're trying to go for reach or scale. Going back to the example we were looking at before, a precondition might be that the prompt is noticeable. So you've heard of alert fatigue, and that's a real thing. And also just from a design perspective, it kind of matters where a prompt lives. So if it's not noticeable, it obviously won't enhance salience. And you can have preconditions later on in the causal pathway, like having the PHQ-9 form available. I should have mentioned that Brian Weiner really helped us think about preconditions as the light switch is on or it's off. So if the precondition is in place, the light switch goes on and the causal pathway can flow. And I mention that because then this other factor, a different branch on the tree of causal pathways, is a moderator. And these are factors that strengthen or weaken the relationship between the strategy and the mechanism. And so these aren't all or none, they sort of amplify or they dampen. And so the moderator in the example here includes habituation to prompts. It might not be that every single provider habituates, but maybe some do, many do. And so that can undermine the overall guideline adherence. And clinic length probably also can moderate. the extent to which PHQ-9s get completed if you have shorter visits. So it's a little bit harder to prioritize, perhaps. If you're interested in causal pathway diagramming as a strategy for designing implementation initiatives, then there's a few papers on your screen that you might refer back to. I really like the Theorizing is for Everybody paper that Rosemary Mesa published last year. It really tries to make it practical, what we're talking about today, to bring theorizing into your intervention and implementation design efforts. So I mentioned at the start that we did a systematic review on of the empirical studies around the globe that examined implementation mechanisms. We found 47 total by 2020, and that didn't feel like a lot. And in fact, there were different types of mechanisms being explored. And so those that actually unpacked implementation strategy mechanisms were, I think it was about 9 of the studies did that. And so it showed us that more work needed to be done to promote the study of implementation mechanisms. And we got a grant from the Agency for Healthcare Research and Quality in R13, which is a conference series award, and we brought together a mechanisms network of expertise over the course of 3 years. It was actually 4 years because COVID was smack in the middle of that. And sorry, I need to move my arms around, but you can sort of see me still. So we had this R13 where we first did concept mapping with several inputs to understand what are the challenges to studying implementation mechanisms. And as you can see with this concept map on the screen, the challenges were diverse, and they range from conceptual challenges to methodological challenges, limited theory that our field has to draw from, and more that I won't go into. But what we did on the other side of concept mapping of challenges is we articulated a research agenda. So you can go right now to the implementation science and implementation science communications journals, and there's a special collection that we have pulled together to advance the science and practice of implementation through the study of mechanisms. And our research agenda isn't up there yet, but we hope it will be soon. You'll find a couple of other papers that bring in implementation mechanisms and grapple with those issues that have been recently published. So I'll wrap here with a few, hopefully additional arguments that are compelling around why mechanisms can help us practically. So I think that I've seen it be the case that when we articulate implementation mechanisms, it helps us select strategies. So you've got over 100 discrete strategies. How do you choose which one to deploy in your implementation initiative? Well, you could consider higher level categories like these: plan, educate, structure. You could consider level of influence, patient, provider, team, organization. But I'd argue as you're thinking all those through, you're probably implicitly thinking about implementation mechanisms. So why not make it explicit? I'll bring in some examples of studies that were funded. We had a couple of implementation science centers in when I was an investigator in my former life. And this was an interesting study where this team was trying to increase HPV screening rates related to cervical cancer. And they did formative work and discovered that risk perception was a huge barrier. Folks just didn't perceive themselves to be at risk. And so we needed to activate this mechanism of personalizing risk for folks. And the teams were testing provision of data. Is that the way to personalize risk, or is it through testimonials? Is that more able to activate this mechanism of personalization? And then the next practical implementation issue that I think mechanisms can help us with is this matching issue that you've heard me sort of reference throughout today, which is that the strategy really ought to match the barrier so that it has a good chance at overcoming the barrier. So this was a really interesting study to me. In this example, the team was trying to increase breast cancer screening among African American and Black women. And the key barrier they were trying to overcome was trust in the healthcare system. And they said they were going to use an implementation strategy of the chatbot to overcome trust. And I was quite perplexed by that idea when they pitched it. But they argued that the mechanism of validating concerns was made more possible by a chatbot who could validate in real time the concerns that were being articulated by the women. And they doubled down to say, we've got a second barrier we need to overcome, and that's ease of scheduling. So these are two really different types of barriers, and the chatbot can address both because it can also surface appointments in real time. So they tested that to see how that worked to increase breast cancer screening rates. Another practical challenge we face in implementation is this tailoring issue, right? So no clinic looks exactly the same from a personnel standpoint, a population it serves, the size of it, the types of expertise they have among staff, and et cetera. The same goes for schools in the same school district. They aren't identical. So there's this tailoring that needs to occur. Well, how do you do that if you're not thinking about mechanisms? And the example I bring back here is depression screening rates, but in this current context, it's not forgetfulness or divided attention. It's that physicians have inaccurate knowledge of their performance. They actually think that their teams are doing better at screening for depression than they really are. And so to overcome that barrier, highlighting a performance discrepancy is really critical in terms of a mechanism that needs to be activated. Audit and feedback is really designed for that. And typically audit and feedback comes from data polls that an electronic health record can deliver on regularly. Well, not all clinics, not all practices have electronic health records. So how do you tailor audit and feedback if you're not centering the mechanism? And so that's another practical way this can be useful. And finally, optimize. So you can optimize for a lot of parameters. Linda Collins and colleagues talk about ease, so the effectiveness, affordability, scalability, and efficiency, I think it is. And there are other things you can try to optimize for, but you heard me mention that implementation strategies keep getting more and more costly and complex, it seems, and practice facilitation, I think, is a good example where practice facilitation is often brought in to help teams come together and enhance their means, motives, and opportunities for overcoming low practice change capability. Frankly, you've got an internal or external facilitator who tries to help you bring a new evidence-based program on board, but it is a really kind of complicated implementation strategy. You can see some of the common activities at the bottom of your screen. So if you center mechanisms, perhaps you can streamline practice facilitation or other strategies to be a little more accessible. I finish off here by suggesting that there might be a next generation of implementation strategy testing upon us, where perhaps teams utilize causal pathway diagramming or theorizing that Roman Kisloff and Paul Wilson and others write about from the UK. Or maybe they're bringing in logic models. J.D. Smith has the implementation research logic model that he published a few years ago that I see a lot of teams bringing in that talks about mechanisms. And Elvin Gang, you heard me mention before, bring up again, he talks about mechanism mapping. These are similar in terms of approaches and ways of thinking, but they're different and they serve different purposes. And I'm eager for the field to grapple with those differences and the complementarity so that we can really benefit from the good thinking. But related to this, we have guidance around strategy specification, reporting recommendations. We have folks talking about form versus function, which relates to, but is different from this core component and adaptable periphery conversation that we keep having. And then the multi-phase optimization strategy talks about components, but in a different way. And then I'll finish off by just acknowledging that when you get into implementation, you start to think about what are fidelity consistent adaptations, what are appropriate modifications to the strategy and ways to tailor and track our strategy deployment so that we can support scaling of promising strategies. So that's a mouthful. I'll leave the scientific content there for a moment and just acknowledge that here at CTRIS within the NHLBI, we are really championing late stage translation research and implementation science, dissemination science, particularly at the intersection of health equity and also in the global arena. And I've got the Trans NIH Institute program announcement for the RL1 featured on the screen. We're signed onto that. And so that's a program announcement that you can consider for applications if you are working in this space. But just a reminder that our job is to offer you technical assistance. So if you have ideas that line up with the National Heart, Lung, and Blood Institute and are in this late stage translation research space, don't ever hesitate to reach out to myself or a program officer. We are literally here to support your good ideas and see if we can't get those funded. And so if you're wondering what is the strategic vision of NHLBI, what spaces do we emphasize, the original 8 objectives are up on the screen for you, but we are celebrating a 75th birthday. And with that came a refresh to the strategic vision. And that includes enhanced focus on community engagement, on health equity and women's health and a variety of other issues that you can find on our website. And then I always like to finish by reminding folks that the National Institutes of Health can be a career path. If you've got junior folks in the room or have ever thought of a career change to influence at a different level, we are currently hiring a branch chief for implementation science and health science administrators, which are program officers in global health, health equity, and community engaged research and implementation science. There's also a director position open at the Institute for the Division of Extramural Activities. So USA Jobs is the place to go if you're ever interested in exploring what is out there. And on that note, I will thank you for hanging in there and open it up for dialogue. I will
So
admit.
much.
Oh, there you are. I was going to say.
Yes, I'm here. I'm
I hear
here.
nothing.
So do any folks in the room have any questions? Yeah.
Dr. Lewis, thank you so much for those remarks. And I really appreciate the way you ended by reminding us that in addition to the science, that there's mechanisms to support this work and jobs available to help administer the work. So thank you for that aspect of your talk. You know, listening to sort of midway through, my mind to all the examples you gave kept going to a term, and I didn't see it in the slide. And then it showed up on the slide, and it was trust, or population trust, or community trust. And I think for a lot of the work that we do, we run into that as a kind of barrier in some way. And I guess just to kind of as a walking around your model a little bit, sometimes I suspect if it's consistent with your theory, that trust could be argued to be a mechanism, it could be a barrier, it could be a moderator or a precondition. And I suspect it's possible it could be all of them to different projects or at different times even. But what is a suggestion around how to think about that? If the goal, I know in your remarks, it was to think about the mechanism, but it is sometimes what we're after is to kind of relocate something. Is that actually the process by which this is moving through, or is it actually shaping the process as a moderator, or is it a light switch as a on off? So I just didn't know how you know that something is a mechanism. We can theorize, but how do you know versus something else on the model?
Sure. It's a great concrete example for us to dig into and a good question. And I'll just I think this is a bit of a repeat of something that I said, but wanted to, I guess, wanted to underscore that I think of mechanisms as just sort of the doorway into thinking causally. And it's about so much more than mechanisms, as you saw. And this way of thinking is intended to slow down, be explicit and intentional, check your assumptions, and it can be a tool or a way to actually grow trust by being explicit, transparent, collaborative with community partners. So it probably needs to have a graphic designer or some expert to make it feel a little more plain language and accessible, which I'll say is happening on the side. So that's forthcoming. But when we brought this to community partners, they've really appreciated like going through this explicitly with us, as opposed to implementers coming in and saying, this is what we propose to do, and not being able to really succinctly unpack the why. And so that's kind of an indirect answer to your question, but you were asking more about how do you be precise in terms of where factors might land on the causal pathway. And I think you kind of answered it in your question. It's locally dependent. It depends on what the initiative is, who the people are, what you're trying to do. I would argue that growing trust is sort of like a starting place before you even attempt to implement anything. But you can certainly then see it show up at any point in the pathway, perhaps. So how do you know that you've got it right? I think a lot of that is actually informed by your partnership. Is there trust in certain relationships among people involved in this initiative that needs to be grown? And like, should we be targeting that? Is that the first thing that we should be doing? Okay, what are strategies we've tried? What should we be doing together to be targeting that, if we want to call it a barrier or an outcome? Or say we have trust and it's a trust across the levels of those involved. But obviously not everyone has the same level of trust. Then it might show up, as you said, as a moderator. So I could go on, but I think you answered your own question, that these factors can show up kind of at any place. It's not like I can give you a list of mechanisms and say, this is the universe of mechanisms, but it's really putting it on the causal pathway at the points where it's locally relevant.
Any other questions?
Maybe I'll add one more response, though, which is to say that we have been asked for a list of mechanisms previously, and we have not produced a list of mechanisms because they are perhaps more useful or appropriately tied to the strategies. And so there's one resource that exists if this work is along the lines of what you all do. You might look to Susan Mickey in the UK. She has a team that authored the Behavior Change Wheel, and they have a website called the Tools and Techniques. And their work has really grown out of the health promotion literature. And so you'll find there's a lot of intra and interpersonal strategies and tools, behavior change techniques there, and less so on the community or system level. But what they've done on their Tools and Techniques website is actually mapped the behavior change techniques with mechanisms that have been tested and show you sort of the level of evidence. And then related, the team that I was on previously, we had an RO1 from the National Cancer Institute. And by this fall, you'll be able to access for 30 of the most commonly used implementation strategies, a full causal pathway diagram. So the job of the team was to actually work through, okay, you've got a strategy called tailoring the intervention. What's that mechanism? What's that barrier? How far is that likely to get in terms of outcomes? And these are, we think of them as micro theories that you can use to like practically guide an implementation or test empirically. So just wanted to flag those resources.
Wonderful. Thank you so much. And if there are, oh, okay, and now we're getting some things in the Q&A. So I'll come see you, Liam.
Okay, awesome. So the first question is, are you familiar with pathway modeling and its use for causal modeling? If yes, how is it different from what you're describing?
So I will acknowledge that there are so many different ways of depicting interrelationships causally or theoretically, depending on what discipline you come from. And so the term pathway modeling, I can't tell if that's like a structural equation modeling reference here, if the person who asked the question can give me a yes, no, or if it's different. I could be more specific in my response. Jennifer, is that you? I welcome you to chime in if so. Yes. Ken put in the chat the website I mentioned, and that is exactly right, Ken. And Jennifer, it sounds like you were referencing like structural equation modeling. And if that's the case, then I would say these are different, but you could probably map them. So causal pathway diagramming, the way our team thought about it was that it could inform evaluation and statistical evaluation. It could tell you what to measure, when to measure it, to establish mechanisms, but it certainly wasn't intended to be duplicative with structural equation modeling, pathway modeling, and serve a statistical purpose. So even though you hear statistical terms like moderators come out of my mouth when I talk about causal pathway diagram, we were really thinking about how do we make sure the field doesn't just build the most expensive implementation strategies, but is really crisp around what discrete strategies are necessary. Do you always need education? Do you always need a electronic health record thingy thing? Or is there something really different to overcome the barriers that you're faced with? So I hope that answers the question.
Another question, which is, I'm interested to hear about any work you might know of that includes community partners in identifying barriers.
Yeah, absolutely. That's probably the most common approach to identifying barriers is by engaging, key individuals, whether it's key informants or representative informants or all the individuals in the local context in surfacing barriers, because by nature, barriers tend to be locally contextualized. Now, having said that, there are sometimes predictable or known barriers given an evidence-based intervention and its fit with the local context or intended setting. So I'm just thinking, for example, evidence-based psychosocial interventions, they're trying to pull more and more that are designed for mental health into school settings, for example. Well, there's some barriers in terms of, time and expertise that you can predict, but they should always be validated and informed and rounded out by the community settings and people that you're partnering with, working with. It makes me want to mention another website that's really, I think, quite useful, and I will try to find it and put it in the chat. So through one of the centers that I was a part of in my prior life, they developed these toolkits for methodological work. So there's a toolkit for causal pathway diagramming on this website if you wanted to pick that up and bring that into your work. There's a toolkit for how to identify and prioritize determinants. So, and the identification approaches include ways of engaging the community. Rapid ethnographic assessment is pitched as a method for not just hearing words from a local community, but embedding and seeing and understanding even how the community physically is structured, how they come together. So observation brought in, as well as, record review and things of that nature. So, and also, as you heard me say, if you've got 601 unique determinants, you got to figure out, what do I prioritize and address with implementation strategies? So this toolkit gives you ideas about how to do that work. So I'll stop with that answer and see what else we've got coming through.
I think that's all we have. Oh, never mind.
Thanks again for this presentation and for the clarity of that causal model. I can imagine using that with partners. So I think that's just a really cool framework. I'm thinking about spaces where maybe we don't yet have an evidence-based intervention. And I'm curious, from your perspective and thinking about implementation science and all of these potential barriers, kind of what you wish folks had in mind, kind of in those early stages of research, trying to design an intervention or thinking about how to evaluate an intervention to create that evidence base. What should we think about up front so that we can do a better job implementing later on?
Sure. Well, so maybe what's top of mind in my first response is that there's implementation science and pure implementation studies where you've got evidence or an evidence base and you're testing strategies. And you're asking about the other space that's really important for us to be influencing, which is designing for implementation. It's bringing implementation science into the earliest phases of clinical translational science, or if you don't, ascribe to the clinical translational continuum, bringing at least implementation science in early. And I think I'm trying to think if there's a really perfect article that I can point you toward, and there's not one immediately emerging, but principles such as, engaging the intended beneficiaries from the get-go is probably the most important thing to do, because we often, feature a specific condition in the context of a person who is whole and has, multiple conditions perhaps, or social risk factors that might not permit certain types of interventions to even reach them. So one of the reasons why I ended up developing a whole line of inquiry in social health as someone who was steeped in implementation science methods was I started to see again and again that we could get health systems, we could get community mental health centers, we could get schools to deliver evidence-based interventions. But if we couldn't get people, patients, parents into those settings, they couldn't benefit from an intervention, delivered with fidelity. So understanding social risk, social health, social determinants of health, and designing with the communities from the beginning, I think is the first thing that I'd want to say. That might be preaching to the choir here. But I think also just having familiarity with, I think of the frameworks, theories, and models from implementation as tools. So having some familiarity with some of these tools can be really helpful in those early phases. So even just looking at the CFIR, which, has these 5 domains of influence, and just keeping those in mind, like, oh, I could be designing an intervention that's not compatible for the setting I intended to be, or I could be designing an intervention that can't be tested, and I know that they should be able to refine it. Or if you're keeping front and center that there's payment structures that maybe I'm not going to change, those types of things can really streamline, I think, ultimate impact. So I hope that starts to answer your question.
Great. Any last minute burning questions before we close out? No? Okay. Well, thank you so much to Dr. Lewis. We can give another round of applause.